Hello everyone, I'm Jeffrey Woldt, Editor-in-Chief of Chain Drug Review. Today, we're here with the second installment of our series of highlights from Health Equity 3.0, the annual summit that we do with Kearney that looks at the issues of health disparities and how they can be alleviated. Today, we will present highlights from a distinguished panel that looked at pharmacy and food deserts. I saw a recent report from the Commonwealth Fund that talked about healthcare in the U.S., and it ranked 10 advanced industrial countries, and not surprising to anyone in this room, U.S. came in 10th out of 10, and we were 10th in health outcomes and 10th in health access. Walgreens is cutting 1,200 stores potentially over the next 3 years. CVS has cut 900 stores over the last 3 years. Rite Aid has cut hundreds of stores. So you have spent a lot of time studying this phenomenon. Maybe you can talk a little bit about what you see and what the problem is and how this will impact healthcare going forward.
Sure. So, and it's also impacting independent pharmacies, right? It's not just chains. So pharmacy deserts are neighborhoods that lack convenient access to a local pharmacy, accounting for poverty level and vehicle ownership. And what we found was that segregated Black and Latinx communities of color are more likely to be pharmacy deserts than other neighborhoods, more affluent white neighborhoods across the country. When we talk about health equity, access, and adherence to medications, what brought me into this area was kind of being frustrated that no matter what we do at the plan level, ensuring coverage, no costs for any prescription, whether it's Medicaid or Medicare Part D, we still saw disparities. They didn't go away just because medications were free. So when stores announce we're closing, pharmacies, it worries me because based on our data, it's going to affect these communities of color more. Communities that already lack access to pharmacies than other neighborhoods. And we found that leads to non-adherence. So when we're trying to measure adherence and health equity, we cannot ignore what's happening in the community. And when we talk about community partnerships and the voices of the community, well, the community is telling us, do not close our stores. We need our pharmacies. This is not going to be solved through mail order.
Pharmacy is the number one accessible health care, right? 90% of the US population lives within 5 miles of a pharmacy. If I take that one further, Good Neighbor Pharmacy stores service, it's 47.7 plus million lower income individuals, and about 9.5 million of those live in areas where they have limited access to pharmacy. It illustrates how pharmacy can play that significant factor in that healthcare space for their communities. But how can we continue to help more broadly is the legislative aspect, right? We need our pharmacies to have fair and transparent reimbursement. It's vital to their economic and financial vitality. And we need to keep pushing for that provider status so they can be compensated fairly for those services of vaccinations and those clinical education opportunities so that they can continue to survive.
We have pharmacies that have been there for 100 years and literally grew up serving their customers and their patients. And so it's painful for them on all levels to walk away from the people that are counting on them. And so that is why we're all investing so much on the advocacy efforts to make sure that not only the fair reimbursement for the prescription services, but the diversification of that revenue. My team focuses on bringing them solutions and opportunities so that we can bring them network-based services even at their individual levels. We've got a partnership with the American Pharmacists Association Foundation that honestly partners with vendors to access some funds, but then does research-based interventions with pharmacists where the pharmacists get paid for things other than filling up their prescriptions. So our theme this year has been revenue diversification. We're hopeful that by the end of the year, no matter what happens with the election, we'll get something in a healthcare bill to alleviate some of the pressures across the board, patient care and some of the pharmacy reimbursement issues. Fingers crossed, we're all working on that. Really focused on making sure every pharmacist stands up and has a voice that reflects the needs of their communities.
I'll just echo that the legislation that's before Congress to essentially allow for reimbursement of pharmacy services under Medicare would be essential and kind of allow for a sea change of other things to happen across the healthcare ecosystem, because many times other payers follow what Medicare does. So getting through this barrier will open up a lot of doors on the reimbursement side.
We need more than just provider status. I think that would make some pharmacies more sustainable, but we do need more. We need reform with pharmacy benefit managers too. They're really kind of the root cause of a lot of the pharmacy reimbursement issues that are driving independent pharmacies out. And if we do not address that, the problem's going to continue. You know, I argue even with expanding scope of practice, if independent pharmacies don't get paid for the prescriptions they fill, it's going to be hard for them to survive in that climate.
We have some programs and services through Good Neighbor Pharmacy that help to close those gaps. Whether it is a pharmacy ownership program that helps connect buyers and sellers within the independent space, that helps to make sure that they stay open and in those communities. We have business coaches who can help those pharmacies expand those services, think about their vision, navigate the challenges so that they continue to serve those community needs.
The resiliency that we keep expecting pharmacy to come out one more time and say, okay, we will. We'll stay in business even when our profit margins are negative. Imagine that if you were running any business. But we also believe that just filling prescriptions isn't the way for any pharmacy practice to continue, and that it needs to be on those other services that we talked about before. And there's a gap. Again, imagine that person who's running the business, doing payroll, filling a prescription, and talking to Mrs. Jones, needing to think about building a room and doing some of those other services. So I think both of our organizations have advisors that will go in, have programs that they can take advantage of so that they don't have to do it alone.
I mean, have you lived in the cities? Have you lived in LA or Chicago? 5 miles is an hour driving. It's taking multiple buses, trains. And if you're old or if you're disabled, that's not fair. If pharmacies are held more accountable to the communities they serve, and policies help to protect that, I think we should be able to see a more equitable distribution of pharmacies. We should have statistics around pharmacy deserts, equity in pharmacy deserts. Not that 1% of white neighborhoods in Chicago are pharmacy deserts compared to 35% of Black and 25% of Latinx communities. While the average is, 90% of the population is within 2 miles, that's not true in many parts of the country, including in rural America.
It is a problem that we have to solve. And it's going to take, it's not just policy, it's not just desire, it honestly would help if all of you activate your local constituency and speak for, because that's where we found the biggest change happens the most quickly. If constituents of some of the local and federal legislators keep raising this issue up. The pharmacies are there for the care of their patients first and not necessarily to use them as advocacy vehicles, but somehow we need to strike a balance of making sure there's enough awareness so that the communities can help protect those valuable resources.
A store closing, a business closing, is a big deal to a politician, but it is those stories of the patients who are then impacted. They can't get the care, their grandma can't get their care, their child can't get the care, where we've really seen our patients in those communities step up and help speak up for the businesses, make so much more impact, because legislators are thinking about the larger community rather than the impact of that maybe 1 or 2 business owners. So that's a way that we can help magnify that voice.
39 million people live in low-income areas with inadequate access to food. Sara, how does that connect to health, and what role might pharmacies be able to play to solve this food access problem, in addition to the pharmacy care, of course?
So poor nutrition is the leading cause of poor health outcomes in this country. So your health, the services that you receive at a pharmacy and elsewhere across the healthcare continuum, and the food that you eat, it's all connected. So I think there's a huge amount of opportunity to think about not only access to food, but nutrition security, access to food that is nutritious, whole foods, fruits and vegetables, and identifying and kind of breaking down some of the barriers. And in many ways, access to care and access to food, we go back to social determinants of health as kind of the bedrock, and education as key factors that play an important role there.
There's a perception that only dietitians can talk to people about their food, but when the question is, the only place I can get food is McDonald's, what do I do? A pharmacist can handle that initial conversation and tie them up to resources. And when they could also write a prescription for a produce box to be delivered or getting them vouchers to go and get that healthier food, that connection can be made, and then the deeper connection can happen with the RDs. It's critical.
Local partnerships is really important, but it's limited by the policies in place that could ensure that those partnerships continue. I think one solution that we found in our research that promotes not only access to pharmacies but access to medications is having on-site pharmacies within federally qualified health centers, which is lacking. I mean, there's a lot of federally qualified health centers. About only 10% of them have a pharmacy on site, and many of them are in areas that are pharmacy deserts.
In my opinion, with public health issues, and I have a public health background, I'm not a pharmacist, I'm just someone who believes in pharmacy as a partner with public health. We're not the only solution, and we bring resources, and we bring opportunity, and we bring access, but we're never going to be able to solve a public health problem alone. There are, FQHCs, there are public health departments, there are other entities in the ecosystem, there are healthcare systems, there are primary care providers that all are looking at equity and looking at communities and figuring out how to fill those gaps.
Next week, our program will address the issue of women's health. Please join us.